for this. So I'd like to begin by introducing Rose Zullinger, who's been the President's Malaria Initiative resident advisor in Mozambique for the last number of years. And she'll be presenting to us on rapid assessment of malaria hotspots in Mozambique.
Thank you. I hope that you're all sufficiently caffeinated for this. Today, as Rick mentioned, I'm going to be speaking about a rapid assessment of malaria hotspots that we conducted in Mozambique. I'll be presenting on behalf of colleagues from the National Malaria Control Program, from the President's Malaria Initiative, and also from the National Health Institute. So I'll briefly describe the context of malaria in Mozambique, and in particular, some potential reasons why we might be seeing an increase in cases or higher cases in one area relative to others. I'll then describe the objectives of the investigation that we implemented and the methods that we utilized. I'll then describe the piloting that we did of this overall protocol and some next steps. So briefly, Mozambique has a population of approximately 29 million people. You can see in the image below that while the country has noted important progress in terms of reductions in malaria mortality, shown by the line decreasing in red, we have had a considerable increase in terms of the overall burden of malaria in the country over the past 5 years. So most recently, there were just over 10 million cases of malaria diagnosed in public health facilities and by community health workers in Mozambique in 2018 that were reported through our routine HMIS system, which is the DHIS2-based platform. We do have malaria incidence of about 358 cases per 1,000, and there is year-round transmission with a seasonal peak. The dominant vectors are Anopheles gambii and Phenestus. And while overall the country has a high burden, you can see that there's considerable heterogeneity in terms of malaria incidence in the country, and also heterogeneity in terms of prevalence. In terms of incidence, there are some areas that have a burden of greater than 650, while areas in southern Mozambique are targeting elimination. But there isn't just heterogeneity at a district level. We also have considerable differences even at a sub-district level. So here we're looking at data from health facilities within one district of Mozambique, Quilimane. And you can see here, as shown in blue, the median number of cases from 2017 to 18 in the first 6 months. And then shown in red, the cases in the same period in 2019. So you can see just looking at this that one, the trends look different even within health facilities in the same district, and the overall burden is also quite different. So why? Why do we see more malaria in some places relative to others? Why are we seeing more malaria cases 1 year relative to the prior years? So based off some experiences that colleagues had in terms of implementing a protocol in Guinea, Mozambique developed a protocol or adapted the protocol to try and really understand why are there more cases. And I think my colleague Mateusz Plasinski really nicely characterized a number of different hypotheses that might explain it. So hypothesis one is that there really isn't an increase in cases. We actually just have a challenge in terms of the data quality. It's also possible that there is a difference in cases. Perhaps there is more malaria in terms of at the health facility or even in the communities. But it might be a result of poor commodity or case management practices. There's also, I've got a slippery finger here. Okay. It's also possible that you're having changes in health care access or health facility access. If you have a large increase in the number of community health workers in an area, you would expect that you would find more cases in that area. It's possible that there could have been a change in terms of vector control access, so perhaps an area that used to have IRS no longer has IRS, or you have reductions in terms of ITN ownership, access, and use in the years following a universal coverage campaign. Perhaps there's been a human population increase. We would expect to see more cases if there's been large migration into an area. And then finally, there could just be differences in terms of the vector population. Maybe we have a resistance growing that's compromising the effectiveness of our interventions, or a transition from more indoor biting to outdoor biting. And it's important to really understand which of these hypotheses or which of them might be contributing to your increase in cases, because they actually should elicit a different response. And so in order to try and understand this, we've in Mozambique through the leadership of the National Malaria Control Program, developed an investigation protocol that really sought to characterize the local malaria epidemiology and entomology in areas that were hotspots, or in the future, areas that are also reporting outbreaks. And specifically, we looked to determine whether there are differences in these hotspot areas as compared to other local health facilities or local districts. The overall goal of what we've been trying to do is to develop an easily implementable, data-driven, and rapid investigation SOP that could be used nationally. So how did we do it? So the first step is to say, well, we're seeing something in our data. That's why we're all here, right? We're interested in data to action. We're all starting to look more and more at our routine data, which is really important. But what do you do when you see that one area is exceeding your threshold for an outbreak? So the first thing that we did was we looked at those data, and we said that Kilimani, the district that I showed you the health facility data for before, exceeded the threshold, and there was in fact an outbreak as defined by, or as reported in our routine HMIS data. So then we go beyond the district and we look at the health facilities within that district. And you can see here, these are the same data I showed earlier, that there are some health facilities that have a much larger increase in cases, and some that actually are showing a minor reduction in terms of the number of cases. So within the district, we were able to select 2 cases, those that were really reporting this increase in cases, and 1 comparison. So we went to 3 different health facilities to implement a 7-day entomological and epidemiological investigation. So the EPI team, I'm not sure, they both had a lot of work, but the EPI team probably didn't have it quite as bad as the ENTO team. The EPI team were collecting qualitative, but then also epidemiological data. So the first thing we did was we went to the health facilities and did data quality assessments. Following data quality assessments, we also looked at the commodity availability at those health facilities and experiences of stockouts. We also conducted structured mixed methods interviews with personnel from the district health office, but then also from each of the different health facilities, including a community health worker that's based in the health, or working out of the health facility. Through those interviews, we were able to identify one specific community in each of the health facility catchment areas that was felt to be contributing in particular to the increase in cases. So we went to that community and we did interviews with the community leaders, and then we did household questionnaires and also testing of all individuals in 30 households that were randomly selected in each of the different communities. To complement this work, a separate entomological team was doing entomological and human behavior collection. So they did that through Procopac collections in each of the communities, larval transects to do larval mapping, and then human landing collections. And the HLC teams, as they were working, they did 2 consecutive nights in 2 households, inside and outside, but they were also documenting the human behavior that they were seeing. So while they were sitting in the house, what were the people doing in the house? While they were sitting outside, how many people were walking by or cooking, to really try and understand also the human behavior element. So that's the overall protocol design. And so we decided to pilot it in Kilimani in June of this year. And you can see here the location of Kilimani within Mozambique. So hypothesis 1 was that there actually is not an increase. We are just seeing an issue related to data quality. And what you can see here, as shown in blue, are we went to the registers and said, okay, what do the registers tell us in terms of the number of outpatient visits, the number of individuals tested and treated, and how does that compare to the monthly aggregate data that then were fed into the DHIS2, as shown in red? So overall, data quality was problematic across the different health facilities, and we've seen that in other routine implementation settings as well. And so, for example, you can see here in the comparison health facility, when we went to the registers, we actually found considerably more cases than had actually been reported into HMIS2. Or DHIS2 rather. Despite these issues in terms of data quality, they were problematic, but it didn't fully explain the differences that we were seeing. So then we went to the communities to say, well, is there actually a difference in terms of community burden of malaria? And what you can see here is that the answer is yes. In fact, within one district, in health facilities that were actually geographically quite closely located, we had a community prevalence of 68% in one, just over 30% in another, and 12% in the comparison. So there truly, at least at the time that we implemented this investigation, was a difference in terms of community burden. So why is that? Is it because of poor commodity and case management? Well, what you can see here in terms shown in the figure in the top left are the number of individuals that were reported to have confirmed malaria and that were treated from the routine data. And you can see that there were some suboptimal, we would want to see those bars the same. And so we do have undertreating of confirmed cases. We also saw that in the community, we asked people if they sought care if they had had fever in the past 2 weeks, and if they sought care, whether or not they received treatment. We did see suboptimal testing and also suboptimal treatment. Nevertheless, for better or for worse, consistently kind of problematic. And so it doesn't really explain what we're seeing in terms of community prevalence and also health facility incidents. So the next question is, well, do we have differences in terms of health facility access? And so you can see here that our comparison group did actually live closer to the health facility. So we would think that they have better care seeking, and yet they had the lowest reported care seeking. And so again, it's interesting, but it doesn't really explain the differences that we're seeing. The next hypothesis was related to differences in terms of vector control interventions. And what you're able to see here is that overall, we had relatively high ITN ownership and access, but it was higher in the comparison area as control compared to the comparison area. And so that could partially explain some of the differences that we're seeing in terms of malaria burden, that you have better access and use of bed nets, you have less malaria. But it doesn't fully explain it. The next hypothesis that we looked at was whether or not there had been a human population increase. Did we have more people coming into the areas? And so we got at that through those questionnaires and mixed methods questionnaires that we used. And health facility and community respondents reported that they had not noted any substantial changes in terms of the local human population. So we can rule out that in terms of one of our explanations. Lastly, we looked at differences in the vector population. So you can see here, these are data in terms of collections from the PROCOPAC that we did in 10 households in each of the different areas. And we did, in fact, find a lot more phenestus, in particular in case 1 area relative to the comparison area. Similarly, we saw a lot, predominantly we're seeing Culex biting, which is in the lighter blue, but we did see considerably more phenestus biting in the 2 case areas. And interestingly, you can see in the dark blue in the case 1, which is on the left side, we also noted a lot of tenebrosus biting. Now, there's no evidence from Mozambique that that is an important vector, but in this area, we're seeing a lot of tenebrosus biting, which raises the question as to whether or not it is an important vector in this microgeographic area. And so we are doing some ongoing testing to see whether or not it's a vector there. So then we also looked at the human activity. Are people perhaps in the case area, are they going more, are they outside more during the biting periods? And what you can see here is that actually our comparison area is where we saw more of the outside, more of the activity during the hours when the vectors were biting. And so these differences in the human behavior don't really explain what we're seeing. Lastly, we did larval mapping and larval density. And so you can see here, those 3 images are transects that were conducted in each of the 3 different areas. And surprise, we did in fact find a lot more larvae in the 2 case areas. And so in summary, these were the different hypotheses that we set out in the beginning in terms of what are some of the reasons why we might see more malaria getting reported through the HMIS system. So going back in terms of data quality, what we found was that there was poor quality. But that poor quality, and that affected our ability to see whether at the health facility level, that was really explaining what was going on. But when we went to the community level, we did in fact see important differences in terms of community prevalence. In terms of case management and care seeking, overall and across the areas, they were suboptimal. And then in fact, the care seeking was lowest in the comparison area. We also saw lower ownership, access, and use of insecticide-treated bed nets in the case area, so that's partially probably contributing. We didn't note anything in terms of population changes, but we didn't note important differences in terms of the local vector population and perhaps also a new vector. So that's a lot of information. And we did this in 7 days. And we did this with a team of largely individuals that were from the local Ministry of Health, including some support from central level. And so I think that it's a testament to what we can really do with data, the fact that we were able to come up with all of these different pieces of information within 7 days. So what comes next? Well, we have a lot of data, right? We have an understanding perhaps of some of the things that might be going on within Kilimani to contribute to the increase in cases. So the next steps are unfortunately fairly limited, which is that we continue to implement the integrated malaria supervision that we already have in place nationally that focuses on stock availability and case management practices, and in particular, some of the issues around data quality, data management, et cetera, et cetera. And also we continue to intensify some of the communication efforts. So that's kind of what's happening for Kilimani, but overall, what are we doing with this experience, with this protocol? So we've now refined the protocol and we're developing an SOP. That SOP is simplified. So, based off the experiences that we had, we noted some things within the questionnaires that could have been consolidated, but the biggest change is that we've decided to remove HLC. It produced really valuable information, but the feeling was that that's not scalable, especially in terms of a routine implementation from the system, because some of the complexities of having locally trained entomological assistants and their remuneration. And so that's kind of the biggest shift that we're having from what I've described in terms of our results and what will be implemented throughout the country. So we're now moving forward to train teams in each of the different provinces with the idea that it's not enough that people at the provincial or district level are routinely looking at their data. They need to know, what do you do next? So the idea is that this SOP is the next step. You've seen an increase in cases, go to the communities and figure out what's going on. Nevertheless, I think a key question overall that actually my colleague Abu mentioned is, well, what do we actually do? When you're in a high burden setting with limited resources, and you find that, for example, here, there's an important difference in the local vector population, but you don't have the resources to then go target specifically additional indoor residual spraying for that area or larviciding or whatever intervention, I think it begs a question that we as the malaria community need to consider is, it's really important that we're using our data, and it's really important that we're taking action to validate and better understand our data, but ultimately we also need to think about what comes next. How do we ultimately try and reduce malaria in those communities? So this investigation, as I mentioned, we did a lot within 7 days, so I'd like to acknowledge all these individuals that I think didn't sleep for 7 days. It was definitely a team effort here, and also thank you for your time.
Thanks very much, Rose. And I think just to point out, we announced this earlier. A number of people have been just arrived. So what we're going to do is, if we do have time, we'll take a couple of clarifying questions. But we have set aside time towards the end of the session to pose questions to the various presenters. So I think if we may have time for one clarifying question. Deus, if.
Thank you so much. This is a great study. I think we have similar problems in so many areas. Just a simple remarks. Are you planning to put this protocol in a public repository so that others can use it?
So I think, PMI overall, we feel that the more that we can be learning from one another, the better. Certainly would need to consult with Dr. Condrino, the head of our National Malaria Control Program, but I think that we don't want to keep reinventing the wheel, and so we'll find a meaningful way